Okay. So hi, I'm Uchenna Nwoye. I am now the youth administrator at SCIG, and we are doing a program, as you know, on disparities in healthcare for Black women.
Yes,
Um,
yes, that's terrific. Great, I love.
yeah. Okay. I'm happy to have you here. Will you be interested in telling us a little bit about yourself?
Terrific. Yeah, so I'm Dr. Sean Wharton. I'm an internal medicine specialist working in Toronto here in Canada. And my main research as a medical doctor and clinical practice as well, research and clinically, I work primarily in the field of type 2 diabetes and obesity. So in this area of obesity medicine is one of the areas that I've done a lot of work in. And in fact, I am the lead author of the new Canadian obesity guidelines that has found a place within the international circuits and around the world. People look to the Canadian obesity guidelines, even in the States, to have an idea of what's the research that's going on, what are the best treatment options. So that's my main area of research.
Wow. Thank you so much. And of course, we're going to be on the lookout for any of your journal entries or books that you're publishing. Definitely very important. Uh, I wanted to then ask and go into more of a detail or understanding of in this profession and looking at different data internationally. I think that over time, of course, I grew up in the States, and so my background is from here. My understanding of healthcare for Black women, such as myself, has always been not to necessarily compare yourself to what it says on the paper. So, for example, if I, for example, wanted to join the military, and one of the processes into joining the military, you have to be a certain weight and size as a woman. And those charts are not necessarily reflective of a person of my stature or really of the majority of people that aren't fitting this one narrative. So, um,
Right. So
yeah.
that's a very good question. That's a very good observation. So what we do in obesity research is we have a definition called the BMI, and that stands for the body mass index. And what that looks at is a person's weight compared to a person's height. So for instance, if somebody is 250 pounds, if they're 5'2", they're in the obesity category. If that person's 7 feet tall and they're 250 pounds, then they are not in the higher weight category. So we don't just want to look at the weight as a number. We want to look at it in relation to the person's height, and that's called the BMI. Now, what the research showed was that as your BMI goes higher and higher, that puts you at a greater risk of metabolic conditions but the challenge is that the guidelines for how the BMI was set up was primarily white males in the 1930s, and it was used for insurance tables, and they did not look at African American women, they did not look at South Asian women, they did not look at the Latino population. So now we know that if we look at each of the different ethnic groups and even racial groups, that the BMI as to where they're healthy versus not healthy is very different than what we saw in the 1930s in white males. So, and the biggest difference that we frequently see is in African American women. African American women can go up to a BMI between 31 and 32, which according to those previous tables, that would be considered in the obese category. And go up to BMI 31 and 32 without having any health problems, any diabetes, any high any high blood pressure. But if you put a white male at a BMI of 32, their risk of heart disease and diabetes is much higher. If you put a South Asian at a BMI of 32, the risk is much higher. So the idea is that African American women can hang on to energy and use energy better, store it in areas that do not cause disease. And so those areas include the hips and the thighs and the buttocks area, not the waist. The waist is the frontal stomach area. So if we think of the people that are getting heart disease and getting cardiac catheterization, which is open heart surgery, it's often belly and the thin legs. It's not the African American woman with the thighs and hips that are actually bigger. So hips versus waist is what we frequently end up looking at. So that's very important. And so it's nice to know that African American women can go up to a higher weight without getting any major problems.
Yeah.
But here's where the challenge is. Challenge is many African American women go well past a BMI of 32 to BMIs of 35, 40, 50, and then they run into all of these medical problems.
Wow. Yeah, and that actually brings up another point. Why is it that, or to your research, really truly, why is it that that this is the situation? Why is it that African American women, such as myself, have the bigger, essentially, body parts in comparison to the 1930s white male, and why is this something that is important?
So, terrific question. So let's define what the population in America. In America, African American women are at the highest risk of obesity that causes medical conditions such as diabetes and high blood pressure. And diabetes is a major problem, right? It can cause kidney failure, it can cause eye damage, it can cause lesions within the legs that don't heal properly and result in an amputation. So what we know is that Ella Fitzgerald, very famous African American woman, had diabetes and died without any of her legs. She had both legs amputated because of her diabetes. So diabetes is real and causes major medical problems. And the number one cause of diabetes is elevated weight. African American women have a rate of obesity that is at 44% versus white women who have a rate of obesity of about 26%. So the question is why is it so much higher, almost double in African American women? And we don't exactly know the reasons why. There may be some genetic components, but likely the bigger reason is socioeconomic challenges. So when we look at class structure or we look at poverty, then we can see that the predisposition to having poor nutrition has likely led to this excessive amount of actually elevated weight. And this poor nutrition started in slavery and then got even worse after slavery. So all the way through, African Americans have had a poor nutrition, have got accustomed to these foods. So like in the southern states where the food is very, very rich in terms of calorie dense, and that's what we want to eat. We African Americans want to eat, not the broccoli or the Brussels sprouts. And so the palate was developed for foods that were higher in calories, that were lower quality, and that is the food that many African Americans still eat and puts them at risk of elevated weight and then at risk of the diseases that follow with elevated weight.
Yeah, so this is really something to look into. I appreciate the gesture, and I appreciate all the work that you're doing. As it may seem like it's maybe some days very tedious, but it's necessary. And I think it's also promoting change. As time goes on, people are changing the dynamics of things, and what is considered um, maybe trend for health may not be for long lasting health. And I think that this is something that our community, our global community, needs to look into and see why is this a problem and how to go about changing it. So I guess my final take would be, what do you think is the best way to move forward, or to decrease the rate of diabetes and obesity amongst Black women?
Great. That's a very important next question. Next question, obviously, is there treatment for this? So if somebody gets to this elevated weight, can they bring the weight down and keep it down so that they're not at risk of these medical conditions? And the answer is yes. We do have effective treatment for elevated weight. It's a three-pronged or three-pillar treatment. And it is based in psychological intervention, pharmacotherapy, or the use of a medication, and then bariatric surgery. So those three things support having less calories. So everyone knows about being on a diet. Problem is when people go on a diet, they can't usually stay on the diet because they get hungry and they want to eat. So the ability to go on a diet is easy, whichever healthy diet you choose. But once you staying on the diet is the hard part. Starting it easy, staying on it hard. So the ability to stay on it is if we can do those three-pronged interventions: psychological interventions such as cognitive behavioral therapy, understanding the relationship that you have to food, emotions and food, stress and food; the use of pharmacotherapy, the same way we use medications for high blood pressure or for diabetes. We now have very effective, safe medications for elevated weight. They're available here in Canada, where I live. They're available in the States also. And then the final, if weight goes very high, is the use of bariatric surgery and weight loss surgery, which is a more of a drastic intervention, but we do so much of the surgeries that surgeons have become very good. It's you're out of the hospital overnight, and it's a much easier intervention. What our research has shown is that despite having these treatments, women of color have worse treatment or a less chance of keeping their weight down than white women do. And the reason why, what our research showed, is that women of color have less access to care. They can't get to the doctors. They can't get the medication. They're not getting the psychological or cognitive behavioral therapy interventions. So the ability to do well in weight management and in diabetes care is primarily due to the socioeconomic structures, structural racism within North America, and we have to battle that. We have to understand it. Doctors have to understand it. The insurance providers need to understand it. The government needs to understand it and provide appropriate care to women of color so that the morbidities, which is the health problems associated with elevated weight, will get much, much better.
Yeah, this is something that I've always kind of kept in the back of my neck. I've been grateful as I've had parents, and I've been working, and I've always had access to insurance, but there's just so many of us that don't have the access or even the ability to get insurance through their job. A lot of jobs offer benefits after a year of work, but it doesn't necessarily mean that when they need the help, that they're able to receive it. I really think it's astonishing that this is something that is still a problem in this day and age, but it is because to want to help people of color is not a priority. And I think that it needs to be. And I think that not only that it needs to be, but it's just people like you really help to benefit and make this change possible to, and also to inform the people that essentially make these decisions, why things aren't working. I think that they sometimes lack the cultural intelligence to make real beneficial beliefs for the common good. So it just means so much that you're doing this. And also, I finally want to say, if you were able to reconstruct an environment, and a healthy environment for food and healthcare available, what would this utopia maybe look like?
Oh, I love it. That's a nice way to try to picture things. So it would look like not just equality, but equity. So we're in a system right now where if we just try to give equal access, that's not going to actually work out, because African Americans are so far behind the white population in America that we actually need a lift. We need a boost. We need more access to care to get up to the level where we're on equal footing. So that's what everyone would like to see. Well, obviously not everyone, but certainly the people who are concerned about this issue would like to see equal footing. So I think that where we have to go is we have to have better socioeconomics. We have to have better government structures, better a education system that actually works better, physicians who are of color so that they can see patients of color and end up treating them better. So all of those things need to be in place for us to see that utopian healthcare environment that treats people of color properly.
Yeah, it's a lot. It's heavy. I know for a fact I there's so many things that I wish I could change. And I really think that this is one of those platforms to do so. I think that by putting this out there and letting people hear essentially our voices, we can speak against this injustice really truly, as it is hurting so many, especially women of color. It's killing us. It's killing us. This is something that's dire and needs to be attended to immediately. I think that there has to be more funding into Black communities in the U.S. and honestly probably as well in other countries too, I would say.
Yes, in ours too, in our country too.
Yeah, in Canada as well. And
yeah. Well, terrific. Thank you, Uchenna. This has been great to spend this time with you to go over some of the research that I've done, some of the observations that I have, and some of the data that is actually out there. But I'm very hopeful that that by having this data and by having people as concerned as you, we'll start to make some real changes. So thank you for this opportunity.
Thank you so much. And it was great having you.
Sure.
Okay. So I need to actually, before I let you go, you just wrote a book. So
I could do what? Sorry,
you just wrote a book?
Oh, no, I didn't write a book. An article, a very big article in the New England Journal of Medicine has come out that you can add.
I want to tag it in the video as well.
Okay,
so that other people
right. So I can send it to you via email. So that's in New England Journal of Medicine. You can get access. Everyone can pull it up free.
Good. Okay.
Yeah, so I think it's great. So I will send that off to you.
Thanks for doing this.
And, yeah, that works. Absolutely. And my baby's crying in the background, so I gotta go. So Uchenna, has been great talking to you. Thank you very much, and I'll send that over to you.
Okay, thank you so much. Bye. Have a good one.
You too. Thank you. Bye-bye.